Aakash Shakya, and I am presenting a paper which was published in the European Spine Journal this year. This paper tries to answer the question whether a high BMI does indeed affect outcomes following minimally invasive TLIF. To begin with a bit of context and introduction to our paper, as you all know, obesity is an independent risk factor for the development of degenerative spine disorders, which is very commonly seen in the old age. It is estimated that in the next 10 years, approximately a third of the world population will be either obese or overweight. Minimally invasive approaches have been gaining popularity for the past decade or so, and we investigated whether these novel approaches can be safely and effectively applied to those having a higher BMI. To answer this question, a study was conceptualized and conducted at Dr. B.M. Central Railways Hospital, Mumbai, which included patients who were operated over 4 years, that is January 2016 to January 2020, having a minimum follow-up of at least 12 months. We used a Swiss Disability Index and the VAS scores for leg pain and back pain as a functional criteria. We also used a number of clinical and radiological criteria, which included radiological fusion at the end of 12 months. We included all the patients who were operated with minimally invasive TLIF for degenerative lumbar pathology aging more than 18 years and having a minimum follow-up of at least 12 months. We excluded patients having surgery for any other etiology, as well as patients who were operated previously and had a concomitant cervical-dorsal spine pathology. This flowchart depicts our study design. We screened for all the patients who were operated with minimally invasive TLIF during the study interval of 4 years and could find 207 patients who satisfied our inclusion and exclusion criteria. These are further subdivided into 3 subgroups, namely normal BMI, overweight, and obese based on their BMI values. This table depicts the demographic indicators. As can be seen, the BMI is significantly higher in the category of patients having obesity or overweight. We notice a significantly high incidence of diabetes mellitus and dyslipidemia in patients having a higher BMI. This table depicts the clinical and radiological criteria that we used for assessment. Of note, we could see that duration of surgery and incision length was comparable across the 3 groups. However, the blood loss was significantly higher in patients having a higher BMI. Similarly, the hospital stay, the day of independent mobilization, return to work was also comparable across the 3 groups. However, the ICU stay was significantly higher in patients having a higher BMI, which can be explained because of by the presence of a number of medical comorbidities. The complications and the fusion rates were also comparable at the end of 1 year. With respect to the Swiss Disability Index scores, the scores are comparable at each point of assessment across the 3 groups, and the scores at the end of 1 year are significantly better to the preoperative scores in each subgroup. A similar pattern was seen in the VAS scores for both leg pain and back pain, with no statistically significant seen at each point of assessment. To conclude, obesity does not adversely affect the outcomes post minimally invasive TLIF. Rather, the advantages of minimally invasive approaches can be safely and effectively extended to those having a higher BMI. Approach-related morbidities, that is, incision, infection, and other complications, are similar irrespective of the BMI value. But a point of caution can be practiced with respect to the statistically higher blood loss and ICU stay, which was seen in patients having a higher BMI. Thank you.